Good morning, everyone. Hope you can hear me. Right. Again, thank you very much, GMOA, for initiating this continuous medical education program for doctors, which is a timely needed intervention, as most of us need to be updated on our topics to manage patients day-to-day basis. Right. So the next we will be talking. I'll be talking about general approach to a multi-trauma victim in emergency department. So I'll be emphasizing on general aspects. I'm not going to uh, detail on specific the specialty things, but I will be dealing with some of the basic approach things which will be needed for us to manage a critically ill multi-trauma victim in emergency departments. Right. So why do we need, I will get, so we need to know why the trauma is important in our country. Of course, over 1 million hospital admissions and over 1,800 deaths in 2017 in Sri Lanka. That means like about 6 or 7 deaths per day due to trauma. And all over the world, in 2013, 5.8 million deaths. Out of that, 1 million deaths are due to road traffic accidents. So it's a burden to most of the countries, and especially the working population is lost or debilitated due to the trauma. So that's why we need to know how to deal a trauma victim, because saving life and saving complications will be important for a country, because you will lose the productive life if you don't treat them well. So these are the figures which says the mortality due to road traffic accidents. If you see this, it clearly says depicted that the mortality rate will be high. The mortality rate will is high in countries where there is developing countries where there is poor healthcare system. So which is important aspect in our country as well. So we need to have a good trauma care systems, and thereby we can reduce the mortality and morbidity in trauma victims. Right. If we don't talk about the history, a little bit of history, it will be uh, not nice, because the advanced trauma life support, which is launched in United States in late 1970s after a tragic accident to an orthopedic surgeon and his family, where his wife and his wife was dead, and the 3 children were critically injured, and he has seen the horrific way of treatment to his family members, so which lead to development of advanced trauma life support course in late 1970s in United States. Give me a second. So after 1970s, there's drastic changes in medical retrieval and aeromedical retrieval in United States, Europe, and Australia, where it has shown there's marked improvement in trauma care. So this is why we need to talk about the trauma deaths and the trimodal distribution of death. So I think most of us has seen this, where within first few minutes, there's 50% of trauma deaths occur. That's mainly due to major brain injuries or major great vessel injuries, and other 50%, or out of that, 30% due to 30% occurs within minutes to hours, mainly due to blood loss and airway problems, and the rest of the 20% happens as late complications of trauma, uh, due to bleeding and also due to any infections. So first 50% we might not be able to help, but the rest of the 50%, effective trauma care systems can reduce the mortality. So I will introduce few terms. One is golden hour in trauma. So that is not a strictly defined time period or the first hour, but early and prompt treatment will reduce the mortality and morbidity. So whenever possible, the treat major trauma patients uh, earlier as possible. So when it goes to the pre-hospital care, we are talking about the platinum minutes. We talk about the platinum 10 minutes, that is first 10 minutes after arrival of the emergency medical services to the scene. So once the emergency medical teams arrives, so they can start treatment. So that is where we talk about the platinum 10 minutes. So there are various ways the emergency medical teams will react to the trauma. Some, of course, with the resources, some teams might do some resuscitation, and sometimes some teams, of course, do the scooping and running. Right, and in Sri Lanka, of course, with 1990 introduction, and there are emergency physicians who are interested in doing retrieval care services. I think in Sri Lanka in future years, we'll be able to run a good pre-hospital care services in our country as well. So the process include the it starts in pre-hospital care in the field, and then once the patient receives to the hospital, the patient will be like assessed primarily, and then rapid resuscitation will be done, and then followed by the going through a secondary assessment, and then go for the radiology and for the definitive treatment and disposition. So this is the process where the patient will undergo following a trauma. So to have a proper trauma system, the patient will go each and every step without any problems smoothly, thereby we will have a good outcome. And one other very important aspect in treating trauma victims is should not get distracted with all these ugly injuries, because as in this picture, the patient might have a very badly injured lower limbs, but the cause of death, the probable cause of death may not be this. The patient might die of airway problems, patient might die of tension pneumothorax. So we have to make sure that we stick to the basic protocols in ATLS to reduce the mortality and morbidity of a trauma victim. So the concepts are, as everyone know, we have to approach systematically, that is the ABCDE approach. And also other important thing is you have to work as a team. So as an individual, you can do few things, but it should be coordinated and should work as a team. So haphazard things can damage the process of ATLS. And also to start treatment, you should not wait until you diagnose this. So once you assess, you have to treat. And most of the time, a detailed history is not available on a trauma victim or the critically ill trauma victim. So you should not delay the treatment saying you don't have the history or you don't have a proper diagnosis. So that is most important in managing a critically ill trauma victim. So as I said, the process starts at pre-hospital care or retrieval services, where uh, the care services is transfer of critically ill trauma victim using a specialized staff with the transport platforms and with equipments. That is done by the emergency medical services. In the Western countries, certain instances where the doctors are also involved in aeromedical retrieval. The retrieval can happen either aeromedical or by road. And there are, as I said earlier, strategies used. Like, some people, of course, use scoop and run strategy, and some, if they have facilities, expertise, they might stay and play. So once a patient is retrieved from a field, the patient will reach to the hospital. So in hospital, we have to have some basic facilities to make sure the patient will have a good outcome. So we have to prepare ourselves to tackle the patient, and the patient might undergo a triaging. So once the patient is triaged, the patient will be assessed primarily and then resuscitation. And we might need to know things about adjuncts to primary survey, which will give uh, important aspects for our diagnosis. Once the patient is stable, and after primary survey, the patient will undergo a secondary survey where the patient will be assessed head to toe. And once the patient is assessed, the patient might, so some patients, of course, once the primary survey is completed, and if the patient is stable, patient might go to a theater. But some people, if the patient is stable after the primary survey, they will undergo the secondary survey, and then they will go for radiology, and lately they will go for definitive care. So this is the process in a hospital with multi-trauma victim. So for the preparation, there are like, if you need to prepare for trauma, so you need to prepare ourselves as human resources. We need to conduct educational programs, skills improvement, and also we might need some of the machineries, some of the monitors. So we need human resources and equipments as well. So this is a place where a major trauma victim is resuscitated. We call it like resuscitation base in hospital, where it's like a intensive care unit with a basic surgical equipments are there, because the patient might need a finger thoracostomy, sometimes emergency department thoracotomy. So this should have monitoring, basic surgical care, and the ultrasonography, everything should be included in a hospital resuscitation there to treat a multi-trauma victim. And there are some other terms, a trauma call, where the trauma call is given by the emergency medical services from a field, where there are uh, criteria to activate a trauma call. It's mainly due to the parameters and also the mechanism of injuries will activate the trauma call by a emergency medical services. So in Western countries, where if the trauma call is activated, most of the time these patients are will be bypassed. The small hospitals will be bypassed. Like, they will go to a referral center or trauma center, bypassing small hospitals where they don't have enough surgical specialities. So that is important to treat a patient without a delay. And because the call is given, the patient or the hospital is prepared to accept a trauma victim, thereby the, the delay is minimized. So in hospital, you will have a trauma team. So as a trauma team, it's a multidisciplinary team which has emergency physicians, anesthetist, general surgical registrars or general surgical team, and also depending on the indication, they will have a specialized surgical teams available. And also some, of course, if you have the radiology facilities, sometimes CT facilities, that team or that team also will be included in a trauma team. Right. So once the patient receives to the hospital, patient will be triaged according to the vital signs, and he will be placed on a resuscitation bay for further care. So as everyone know, the primary survey includes A, B, C, D, E, and airway with cervical spine protection. That is the first step, and the breathing and ventilation, a circulation with hemorrhagic control. But if there's exsanguinous bleeding, so the hemorrhagic control sometimes can come up in the list. So once you are done circulation, so you need to have a brief neurological examination, and finally, so you need to expose the patient with environmental control. So as a team is involved, so in practical way, so so most of these things can happen simultaneously, because airway doctor might be taking care of the airway, and the procedure doctors or the other ones might do the B and C simultaneously, or D simultaneously. So the most important thing is, in ABCD approach, if you see any signs of instability in this patient, make sure you reassess these patients. So you need to reassess patients in subsequent quick times, where if you see any instability in any of the condition, any of the A, B, C, D, E, you need to reassess this patient and adjust whatever you need to be corrected. So our ultimate goal in treating or resuscitating a trauma victim is to avoid hypothermia, acidosis, and coagulopathy. That those are the lethal triad of death of a trauma. So when you are resuscitating, make sure we don't make sure we prevent these three happening. So our aim is to correct all these three to make the patient to uh, make him a survivor. So airway. So how do we evaluate airway? The most of the airways in trauma victims are not tested. So we take all the airways as a difficult airway in emergency department. So make sure when you are preparing for airway equipment, you prepare with a difficult airway kits. So you need to have a difficult airway trolley, prepare for the worst, and so you need to have plans, rescue plans. One, if a plan fail, you need to have a rescue plans. So the simple way, how do we know the airways pattern? Like if the patient is able to communicate verbally, you have a good idea that the patient's airway seems to be fine at that time. And what are the signs of threatened airway? So you need to see whether the patient is having a stridor, hoarseness, or any secretions or blood and some other foreign bodies visible uh, in his airway. So it's a sign of airway threat. And all um, the patients coming with multi-system trauma, uh, you have to suspect that the cervical spine is damaged unless proven otherwise. So you need to clear the cervical spine, both clinical aspects and it also from the radiological aspects as well. So whenever you need to do some intervention in uncleared cervical spine, you need to do it with manual stabilization. So when you are transferring a patient with suspected cervical spine injury, you need to stabilize it with headlock, head straps, and body straps as well with the cervical collar. Right. So uh, so when you see any uh, threatened airway, there are some maneuvers you can do. George thrust is the one we use. We don't do the chin lifting maneuver. And depending on the situation, sometimes you might need oral or nasal airways, but be careful if there's uh, any evidence of basal skull fractures, we don't go ahead with nasal airways. And also If the patient cannot maintain the airway, we might need definitive airway with earlier we call it rapid sequence, now we call it like drug assisted intubation with cervical spine control. And when you are intubating, there are concerns over the cricoid pressure and external laryngeal manipulation. Some, of course, use these things, and there are doubts in whether it is practiced or not. But depending on the expertise level, some people, of course, practice these things in their facilities. So for the intubation, video and optic imaging techniques are preferred, and also the tube placement should be confirmed with a end-tidal carbon dioxide level. As I said earlier, we should have rescue plans if one plan is failed. And needle cricothyroidotomy and surgical cricothyroidotomy will be a final option if intubation fails. Right. So the spinal motion restrictions or manual inline stabilization can do for any interventions when you are doing in a suspected cervical spine injury. So when it goes to the BRE, so we have to do the basic things as inspection, palpation, percussion, and auscultation, and you have to look for signs of deviated trachea, crepitus, failed segments, and sucking chest wounds. So there are 6 life-threatening chest injuries. There are some other there are a lot of chest injuries, but there are 6 life-threatening chest injuries where we might have to pick up in our primary survey. So one is tension pneumothorax and the open pneumothorax or the sucking chest wound, and massive hemothorax. That is, so once you put the IC tube, if you have more than 1.5 blood stat coming or more than 200 milliliters over 2 to 4 hours, and some of the airway disruptions, cardiac tamponade, and failed segments are life-threatening problems when you have to detect during your B assessment. So cardiac tamponade will be difficult in a busy ED setup to diagnose clinically, but as everyone say, Brecht-Triad or can use. Some you might see the clinical signs of Brecht-Triad, but the cardiac tamponade will be identified using point of care ultrasound. Right. So this is a picture of a tension pneumothorax where you will see deviated trachea with collapsed lung. So this need decompression, where if you have facilities, you don't need to go with the needle decompressions. So in emergency department, what we do is, like, if you see tension pneumothorax, we do the finger thoracostomy in a safe triangle, mid-axillary line in 4th or 5th intercostal space. But in a periphery, if you do not have facilities, you go along with the needle decompression, again in the same place, in the safe triangle, mid-axillary line, 4th or 5th intercostal space. And if you are inserting a chest tube following that, you can insert a chest tube with the gauge of 28 to 32. People, of course, use the they are saying that if it is a purely pneumothorax, they will go prefer for a small tube, and if you are suspecting hemothorax, they will go for a bigger one. And if you find a sucking chest wound in periphery or in a field, you can have occlusive dressing, 3-sided occluded and one side is open to prevent air sucked in. And once the patient is coming to the hospital, you should never put IC tubes in a sucking chest wound. IC tube should be placed with the normal on the mid safe triangle in a mid axillary line, and the sucking chest wound should be explored and closed carefully. Right. As I said earlier, the point of care ultrasound has placed to identification of the pneumothorax and cardiac tamponade as well. So this is a picture of a chest tube placement in a trauma victim. So when it goes to the circulation, so all the trauma victim, if a trauma victim comes with a shock, we have to suspect hemorrhagic shock unless proven otherwise. There may be a bit, the patient may have had like other shocks like tension pneumothorax causing obstructive shock or some neurogenic shock, but make sure you don't miss hemorrhagic shock in a major trauma victim. So you have to assess the hemodynamic status using pulse rate and blood pressure, pulse and blood pressure, and capillary refilling time with consciousness. So this is very important slide in our clinical practice. These are the classes of hemorrhagic shock. So you take heart rate, blood pressure, pulse pressures, and urine output, and consciousness to assess this. So there are 4 classes, class 1 to class 4. Class 1 says like it's less than 15% and there are no clinical signs. Starting from the class 2, there's a tachycardia. So if a patient is coming with normal blood pressure with a tachycardia, there may be some there are enough indications for a tachycardia, but in a trauma victim, if you see somebody with a tachycardia and evidence of bleeding, so it's about 30% blood has lost, like 1/3 of blood is lost. So you need to assess these patients and have to keep in mind that the patient might need blood. So delaying blood administration can increase the mortality. And so in class 2, so you will see a tachycardia, but the blood pressure may be normal, but there may be high diastolic pressure causing low pulse pressure. And in class 3, this is the these are the commonest presentations we see most of the time, because we have some delay in presentations where major trauma victims are coming with tachycardia and low blood pressure. So approximately they have lost about 40% of blood and they need blood. So if a trauma victim coming and if there are signs of blood loss, and if we'll say like in a point of care ultrasound says there are free fluid, and if the patient is having tachycardia and low blood pressure, that patient need blood. So you need to get a white bore cannula to the cubital fossa. You need 3 investigations at the time of insertion of the cannula at least. That is, you need the hemoglobin level, you need the blood gas analysis, and you need DT and cross match. And so once you take the blood, so you inform the blood bank, you might need an uncross match blood for the victim. And the class 4 is the terminal stage where there is more than 40% blood loss and the heart rate is extremely high, and also sometimes you will see a bradycardia as a reflex. And so these patients need a massive transfusion, but most of the time the resuscitation may not be successful. So these are estimated amount of blood losses. The pelvic fractures, if there's a pelvic fracture, you can have at least about 2.5 liters blood loss. Femurs about 1.5 blood liters, and tibia fibulas altogether they can have about 1 liter blood loss. And the humerus, other things are minimal blood losses. So if you suspect a pelvic fractures, make sure you will reserve blood because patient might need blood. Right. So as I said, so you have to have a 2 large bore cannula, and you need to resuscitate fluid. So how do we resuscitate? So you need to resuscitate initially, because on admission there are no blood available, however much you need. So you might need at least 5 to 10 minutes to get the blood from the blood bank. So you start warm isotonic fluid. Uh, so the fluid you will give one, uh, the maximum amount will be 1 liter for adult. So after 1 liter, the next step will be blood and blood products. So early use of blood and blood products are indicated, and it has shown that early usage of blood and blood products will be advantage in survival of the patient. And also it will be important in preventing coagulopathy and thrombocytopenia. And also uh, failure to respond to the crystalloid and blood in initial stages, which might need immediate definitive interventions. So if a patient has received a normal saline 1 liter and ongoing blood does not pick up the blood pressure adequately, might need definitive interventions to stop the hemorrhage or stop the bleeding. Right, few words about damage control resuscitation, where there are some aspects. One is hypotensive resuscitation, that is to maintain the perfusion to vital organs with less risk of bleeding, because we need we don't keep the normal blood pressure in these patients, because if you pop the clot, so there will be bleeding continuously. Continuously. So you need to have reduced uh, blood pressure comparing with the normal blood pressure in these patients. So we call it hypotensive resuscitation. Usually our targets will be systolic 80 to 90. And you need to have hemostatic resuscitation. That means you need to give early blood and blood products in these patients. So as I said earlier, your maximum crystalloid will be 1 liter followed by blood and blood products. And after the resuscitation, so as I said, like, you can't keep hypotensive resuscitation for so long. So because there may be problem with perfusion of the other organs as well. So once the resuscitation is completed, so you need to go for a damage control surgeries. The damage control surgeries are brief surgeries where they are more concerned about controlling the hemorrhage and spillage control. And so they should be completed within 60 to 90 minutes. So they are brief surgeries, and they do not intend to correct everything anatomically. They might go with stomas, and they will get the patient quickly to the ICU for resuscitation further. And then they will go for definitive surgeries later on once the patient has reserves. So this is important, and of course certain units are practicing, some countries are practicing a damage control resuscitations in trauma victims. And we will talk few things about the coagulopathy that is very common very common occurrence in severe trauma. So if a patient is having already on anticoagulation, we need to reverse the anticoagulation. And the coagulopathy can happen due to various reasons, uh, like starting with blood and blood products. So you can have dilutional coagulopathies, and acidosis, hypothermia, everything can contribute to the trauma coagulopathy. And there's another entity that is trauma-induced coagulopathy. Again, that is mediated by cytokines and not related to any of the other things mentioned earlier. So to tackle the coagulopathy, you need to administer blood with blood products. Usual thing is we tend to do the 1 to 1 patient basis where packed cells to FFP and then interchangeably platelets and cryo. TEG and TEM or point of care testing is uh, is important in some aspects where you can give uh, required amount of blood and blood products, and should thereby you are not overloading the patient, and to with that you might reduce some complications as well. And the role of calcium is debatable. Again, like if the patient has uh, evidence of low calcium levels, you can give calcium, but with the normal calcium level, no special benefits has been seen. So as I said earlier, hypothermia can contribute to the coagulopathy, so make sure you will give warm fluids, and if the patient's temperature is low, you need to get the measures to improve the temperature by other means. The role of tranexamic acid. So it has been proven with the trials like CRASH 2 and CRASH 3. Introduction of tranexamic acid within 3 hours of the injury is beneficial. So you will give 1 gram of uh, tranexamic acid over 10 minutes, and also followed by a bolus, again 1 gram over 8 hours. So there are evidence that it will be beneficial in patients with multi-trauma and head trauma as well. Tranexamic acid will be beneficial for patient care, survival. So when it goes to the a brief neurology or disability assessment, so you do a brief neurological examination, level of consciousness or GCS, and pupillary size and reactivity, and also do not forget blood sugar levels in your assessment. So everyone knows GCS, like the lower score is 3 and the maximum is 15. The head injuries are classified according to the GCS. Up to 13, that is mild head injury, 12 to 9, moderate, and less than 8 is regarded as severe head injury. And when you completed the brief neurology, so you will go along with the exposure. So you need to expose the patient, and if the patient is if the temperature is low, hypothermic, you might need some warm blankets, external warming methods to prevent hypothermia. As I said, it can contribute to coagulopathy, acidosis, and it will have adversely affect the patient's survival. So if the patient is stable, so you will complete the primary survey with log roll and inspect the back. So log rolling and inspecting the back is one of the important things we might miss. Important things we have to do in emergency department or in primary assessment, because there may be some injuries we might miss if we don't do the log rolling. But the only problem is sometimes if the patient is already unstable, we might not be able to handle the patient for log rolling. And there are methods of doing log rolling. 4% or 5% log rolling can be advocated, but recent ATLS shows it's 4% log roll. That's why I have taken this image from the ATLS. So you need to inspect the back, look for any deformities stepping up and down, and then late final you have to do a PR to see what is the rectal tone is like. So once you complete the primary survey, if the patient is unstable and you have given blood, everything, so if there are signs of bleeding, and if you think patient might need some interventions, the patient might go to theater. If a patient is stable, the patient might go along with the secondary survey from head to toe thorough examination. And there are some important adjuncts to the primary survey where it will be beneficial for us to come to diagnosis. For example, for ECGs, pulse oximetry, uh, capnography, and blood gas. So we will be talking about the blood gas in another 15-20 minutes time as well, and some other urinary and gastric catheters for the indications, and fast or the focus assessments of sonography in trauma. And of course, we don't see much of a diagnostic peritoneal lavages now. And also, if there are mobile X-rays, so these things are adjuncts to the primary survey, which will be important to come for us to come to some of the diagnosis for us to treat this patient. So I will be talking very few things about FAST because this is very commonly used one. So everyone in working in emergency departments or in critical care settings are using fast scans, using ultrasounds to do fast scans. So there are 4 views, as everyone know. So goal is to evaluate for free fluid, not to do any other hi-fi things in ultrasound, but just to see whether there are free fluid in any of the 4 windows we see. And also the other important aspect is we have to we can identify uh, cardiac tamponade, and also if we can go if we can find the hemothorax, uh, one of the benefits of the ultrasound as well. And this is how we diagnose pneumothorax using point of care ultrasound. So there are 2 signs where, like, if you see a barcode sign, you can think of it. It can be a pneumothorax, and also if you see a seashore, that is the normal ultrasonic appearance without a pneumothorax. So the ultrasound in chest is uh, specific and sensitive, equal to chest X-rays or more than that as well. And so once the patient is complete, once you complete the primary survey, the patient will go along with the secondary survey. So one of the doctors will assess him detailed. So you will get a ample history, that is a brief history with regard to allergies, medications, past medical history, last meal, and events followed by. So you might get some information from the bystanders or relatives, and then you do the physical examination from head to toe. And then so you will again reassess this patient uh, with regard to whether there's any deterioration of the vitals. And then if the patient is stable, patient will go for a diagnostic studies. For example, the patient might go to a radiology department or for a CT or other chest X, trauma series chest X-rays. So there are some signs of head injuries. So you might elicit in your secondary survey, like raccoon eyes, battle sign, and hemotymphanogram. And also in the abdomen and chest, you might see sometimes a seat belt sign where you might think of intra-abdominal injuries in this situation. So diagnostic aids include radiology and blood analysis as well. So you will do a standard trauma bloods, like full count, electrolytes, ethanol levels, blood, and coagulation profile as well. And also the trauma radiographs include chest X-ray, pelvis, and of course the cervical spine will be included in a CT most of the time to exclude cervical spine injuries. And as I said, so once the patient is stable, patient can go to a radiology for CT scans. And when the patient is in radiology, because it might take some time, patient should be monitored. And also the other important thing, unstable patients should not in a radiology unit. So if you stabilize a patient can go to a radiology, because there are some adverse things can happen, because the radiology set of x-rays and CTs might take at least 30-40 minutes. Patients without a monitor, unstable patient goes, the results will be disastrous. So this is a picture showing a pelvic fracture. So if you see a pelvic fracture in a patient, the trauma victim, you know that these are unstable fractures. You might need some measurements like pelvic binders and early blood and blood products, and orthopedic team involvement for later definitive care. And this is a CT showing EDH with a midline shift and a cerebral edema. So this kind of patient, depending on the GCS level, you might need intubation, and also you might need some measure to reduce the intracerebral pressure, 3% saline, starting of 3% saline. And if the patient is intubated, you might need neuroprotective strategies to reduce the ICP. So this again picture of STH. So it shows like there's a evidence of brain honing, so you need intubation and neuroprotective strategies before surgical intervention. Right. So once you diagnose all these conditions in a trauma victim, it's important for us to think about the disposition. So as I said earlier, the patient disposition, like if the patient is unstable who need a definitive care, the patient might go to a theater directly from emergency department. And sometimes unstable, so once you resuscitated, if there is no acute surgical interventions needed, the patient can go to a HDU ICU facility and then resuscitated further. So the other important thing for us is, if we need to transfer this patient from our hospital to another facility, we should coordinate the efforts, because it's very important. It will reduce the delay in a the referral center, because we have seen a lot of transfers where they do, the very critically ill patients are transferred without coordination, and we had adverse effects on the way to the hospital. And also once the patient received to the hospital, if the receiving end does not know, if the receiving does not have the facilities, it should be a disaster for a patient, and all the efforts done by the previous team will go in vain. So make sure when you are transferring a patient to a referral center, coordinate before transferring. So you need, again, the other important thing is, if you are transferring, please stabilize a patient before transfer, because we have seen some patients are transferred just like, as I said earlier, like if you see some injury, you transfer this patient, or you need a head CT, but the patient can die with a abdominal bleeding. Right. In summary, so what I wanted to highlight is, the trauma is best managed by a team approach, and so the teamwork will have a good outcome in trauma management. And also, once the patient receives a thorough primary survey and secondary survey, is to key to identify life-threatening injuries, and also might need to treat them then and there. So once a life-threatening injury is discovered, intervention should not be delayed, and you should not wait for a history or definitive diagnosis. And the disposition is determined by the patient's condition as well as the available resources. So I think this is what I'm going to do with regard to management of major trauma victim. So I didn't focus on specialty things. I just wanted to go through a general approach of a trauma victim and what to do in emergency department, and highlighting few key aspects of things we might miss in our management. Uh, Thank you very much.